So thank you for being here. Thanks to Alison for the kind introduction. Today is a collaboration, as you're aware. It's my honour to be here, my first ever EHC-iADH, and I've loved meeting people. It's such a friendly and buzzing atmosphere during coffee, so that was lovely. But as we know, we're here, and I've been invited by the European Haemophilia Consortium to talk to you about oral health and oral bleeding with Willebrand's disease. We understand from Alison this morning that the community are wanting to change the word disease to disorder, so I think that's a very positive step. As she also mentioned, I'm a consultant in restorative dentistry at the Royal London Hospital. So I'm a bit of an oddity in this arena. I appreciate that. And it just goes back to how old I am. I've been looking after patients with bleeding disorders for 20 years, long before we had the experts in the room that we have today who are experts in special care dentistry. I'm also the chairman of the Dental Committee of the World Federation of Haemophilia. I'm in my second term, and as you heard from Alison, it's all about collaboration and communication. So I'm very happy that we have a North London adult haemophilia network, which helps us to improve access to more patients in my local geography. So today, really the aims and objectives, I want to discuss the importance of oral health. Alison said just do the dentistry part. And obviously the prevention of oral disease, a very good point made by Dr. Kumar earlier about bringing the mouth back into the body. And it's really important to understand how oral disease affects our patients, and particularly those with von Willebrand's disorder. I really want to sort of stress how important general practitioners are in improving the quality of life and care of these patients, because a lot of dentistry, by far the majority of dentistry, can be safely and effectively looked after in primary care. And I think that is the best environment for many of these patients, because dentists are able to do that sort of regular surveillance, spot things early, keep treatment simple, straightforward, effective, pain-free. And that's better than waiting for things to go wrong when they need to be referred into us in hospitals. And really the positive impact, I mean, you've heard some of the very, the patient's experience, their lived experience. You know, they do have very big challenges on a daily basis. And it's really important how we can make an improvement and impact on the quality of life. So this is a session about von Willebrand's disease. So we've heard this morning through Kate, and I learnt a lot about how complicated the diagnosis is. But von Willebrand's is a primary hemostatic disorder, so that might be why it has a bad reputation, because that's when you first, your initial bleed, your primary hemostasis doesn't work as well. We're all very good at managing patients with people with haemophilia. We know what factors are missing and we can support the hemostasis in those individuals. But von Willebrand's can present in a number of ways. But it is quite a mild disorder, so it's important to understand that whilst it is the most common of all inherited bleeding disorders, and we've heard again, my statistics are not going to be different, it affects 1% of the population. So we are bound to see these patients who can be undiagnosed, and sometimes it's very important to realise that dentists can be the first people to become suspicious of a bleeding disorder. And usually it's in the primary dentition when teeth exfoliate and they bleed way more than the parent was expecting. But because it is inherited, sometimes these children are managed with parents who know exactly what to do. So that's also a positive, actually. And whilst we've heard this morning about the type 1 is the most common, it's 70% of all disorders, and type 2 is the moderate one. It's a qualitative and quantitative affecting the synthesis. So you might have the right number of factor, but it doesn't work very well. So it's a little bit different, and each individual has their own bleeding phenotype, and that's why dentists should be aware of how this person bleeds. It's not just about their diagnosis. We can't get too hung up on their specific diagnosis, because somebody with the same diagnosis will bleed very differently to another. So understanding that is important, so that you're not so worried if somebody bleeds more than you were expecting. Thankfully, type 3 is very rare, as we heard this morning. And the sort of take-home message with von Willebrands is also that men and women are affected equally, and of course it can be acquired. And thanks to Kate for talking about that earlier. So, going back. Now, thinking about, I was really interested to see the demographic of the patients that were in your study, older people. And this is just some data. We're looking in the last few hundred years. And if you look as a global, as the timestamp goes up, you will see what is really, really important for us to understand is that the life expectancy of people is going up globally, albeit still a few global inequalities. You'll see that there are countries still with a low life expectancy, but we're going really right up there. So in 2019, if you're in the UK, your median life expectancy is 81 years. And so why is that important to us? Well, if you're thinking about it's the most common of inherited bleeding disorders, and life expectancy is going up, the global population is going up, you're going to see more of these individuals in primary care. And, they're keeping their teeth for longer. Okay, this is UK data, obviously, but we're having an increasing prevalence of individuals who are keeping their teeth for longer. And their expectations of oral health, is going up. People want to keep their teeth for longer. They want to have access to care, and their important appearance and aesthetics, things that are normal now, which weren't before. So we need to be prepared for that. You're right, it is the World Federation of Haemophilia, and the guidelines are that, but there are some new published guidelines for von Willebrands from the World Federation of Haemophilia, and Alice is not here, but I know how much she lobbied to make sure dentistry was included. It's not enough, but it is in there, so there are some guidelines for von Willebrands at the moment, but it's much the same. So the mission statement for the World Federation of Haemophilia is to improve access to all. And really their guidelines that were written originally in 2006 and revised in 2003 still stand. We're talking about making sure people have access to care, minimising the use of factor concentrates. My work at WFH has just given me even more understanding and insight into how privileged we are to have access to all of these expensive products, and it's not the same across the world. So the more we can do to improve care with dentists means we don't need to have expensive factors, the better. And the majority of people can be safely managed there for routine dentistry. We really are only thinking about trying to, Dr. Kumar said how hard it is with our limited resources. If we only have to manage the really severe cases or just the minority of dental treatments that need factor support, that means it's better for everybody because everybody will get access to care. Yes, extractions need to really be in an environment where you can have close communication with your haematology team, but if we've done our job right, hopefully that should be fewer than is currently the case. Okay, and we really only need to have replacement therapy, and this includes von Willebrand's disease really, for things that are very invasive and going to cause a lot of bleeding. We limit it to just extractions, surgery, whether that be implant surgery, oral surgery, or periodontal surgery. And in the past, some anaesthetics have also meant that we should give factor replacement therapy. And I spoke to the authors of this guidelines and said, where did you get that information from? And they said there was so little evidence that they basically just copied the warfarin guidelines. Why? Because a bleed in a closed space, particularly where there's an inferior dental-alveolar block, is dangerous because of the location, and particularly in the lingual infiltration area where it could compromise your airway. But thankfully for us, infiltration injections, you can see the bleeding spot, you can put pressure on it if it bleeds, it's much easier to manage. So therefore they don't need to have cover. And the advent of buccal articaine injections, I'm not sure if you have access to that in your clinics, but certainly it's got great efficacy in lower teeth, so we very rarely give ID nerve blocks anymore. So if we can give a buccal infiltration for lower teeth, particularly for restorative procedures, these patients then can have access to this care without needing to have factor replacement therapy. So I know it's routine, but really prevention is a priority, and it's very easy to underestimate that and want to go on to the sort of more invasive stuff and the sort of how we manage them when they're in our chair. But really prevention has to be a priority. We've talked about why, and really if we have a healthy periodontium, then the patient's experience is going to be significantly less a problem, because we don't need to have as much invasive dentistry. If we don't need to have as much invasive dentistry, we don't need to have as much access to von Willebrand factor and all of the other supporting team that we need. We're going to have less complications for patients who then go on to develop inhibitors or antibodies to platelets. Even if they're HLA-matched platelets that we give patients, they develop antibodies to them, so that makes it more difficult, and then they need even more expensive products to manage their hemostasis, which they are expensive. So of course we can help our haemophilia centres keeping their costs down, and not least because these people want to be normal. All right, they want to lead normal lives. They don't want to come to a hospital scenario just for their dental treatment. Okay, so if we could have a dental home for all of our patients, then individuals can look like the image on the left instead of being neglected and just coming up to the hospital when they're in trouble. And that could happen in primary care, within the community, if we can, empower these individuals to go. And the reason I said that normal dentists are better placed is because we all have finite resources in hospitals, okay? And dental pathology doesn't always cause pain. And over 90% of dental disease is preventable. So who has better access than your regular family practitioner who sees you all the time? You see on this patient, they don't have any pain, okay? They don't know anything is wrong, but it will be the dentist who takes their routine radiographs to see there's massive issues going on that need intervention. And that could have been spotted many, many years before, and so that the patient doesn't have to end up losing teeth and get referred. Patients also have a role to play in this, and empowering them is very difficult. We've heard this morning they've had bad experiences. It's not unusual that they're going to be anxious and not wanting to attend. So winning them over is important. The colour you see here, you probably all have access to. It's just a simple food dye. It just shows you how reluctant they are to brush their teeth. And that might seem really odd to us, but actually, when they brush their teeth, they end up with uncontrollable bleeding and coming into hospital. Sometimes my patients turned up in an ambulance, It's horrific for them. So trying to make sure that we get that prevention in early on is really important. And to make sure they understand that they don't have to put up with it. It's not a feature of their bleeding disorder. And I love this because it's, I lead the prosthodontic program at the Royal London, and I always talk about complex treatment fails complicatedly. Okay, so again, why prevention is important is we don't want to have lots and lots of complex restorative things that can go wrong. Okay, and prevention is really the only way we're going to do that. My second favourite saying is that we really want to concentrate on prevention. It needs to be that important. I'm really good at what I do, but actually doing it is bad for our patients. It's much better when we don't have to do anything. And this is just simple, routine, primary care where it's a patient I saw in the hospital, sent them back to their dentist, and they came back with some basic dentistry in a much better place. We've talked a lot this morning about quality of life, and it's important not to underestimate that. I won't go into too much detail because it's already been covered, but it is really high on these individuals in terms of their day-to-day. Okay, it isn't just the absence of pain and problems that they need to have dental intervention. Okay, they don't enjoy eating food the same as you and I because they can't taste it. They have the constant taste of blood in their mouths. And our patients say they don't even like to go out to eat because if they bite into a sandwich, there might be blood on the bread, and then, it's embarrassing for them. And if you have blood in your mouth all the time, the bad breath is actually quite significant. And and it's before we had to wear masks for everything in COVID. It was really nice to be able to greet a patient and try to make them feel a bit better about themselves, but it is quite significant. Intimacy issues we've talked about, and the association with systemic disease. It's really important not to understand, to underestimate that. And the problem is, it's quite simple but quite complex, because the most common symptom of gum disease or periodontal disease is bleeding when they brush their teeth. But because the dentists, the doctors, and their experience is exactly that, they just think that is completely normal. Okay, you look at those gums and you think, my goodness, I just have to look at them and they're going to bleed. So it's no real wonder that people put up with this sort of thing, thinking it is a symptom of their bleeding disorder. If you add to the fact that for these individuals, that periodontal disease is the most common inflammatory disease in humans, and it affects 50% of the world's population, almost 80 or 90% of the UK population have some form of gingival inflammation. So it's not surprising that it's quite common. And then you take a rare disease and you think, well, the prevalence of bleeding in these individuals is high. It's not rocket science, because it is a very, very common infection. But now we know so much more. It isn't just the mouth, there's associations with periodontal disease in all of our systems. It's very, very difficult to underestimate this now. And what's even more interesting is we are talking about putting the body back into the mouth, when actually, if you look at it, I just Googled before I came, cardiovascular disease and oral health. There were 3 million articles written about it. It's not new, do you see? And we're having these patients are living longer. So they have more complex medical histories. They're going to have some comorbidities that are going to impact on their general health, where their oral health is important. Okay, so we know that periodontal pathogens are going to increase the inflammatory burden. We know that we have a heightened state of inflammation in these individuals. There was some work done years ago where they mapped the surface area of periodontally involved teeth with somebody with gum disease. Mapped the surfaces of the inflammatory area that was the area that was inflamed, and they mapped it to somebody's entire shoulder and deltoid. And they showed the doctors, what would you do if you had a patient with this much inflammation? And they said, you take them into hospital and you put them on IV drip, and antibiotics and fluids. But people walk around like this all the time because it doesn't cause any pain. They don't know. But we do know that if you treat the periodontal, this is work done by Professor Diauto at the Eastman actually, he showed that if you treat the periodontal disease, those inflammatory markers go down, the inflammatory markers that are so important in cardiovascular health. So it's not just heart disease, it's diabetes. Nearly 3 million articles, okay? We know this, but of course, doesn't always, the medical profession looking after people with bleeding disorders doesn't always translate, they don't join those dots together. And as these individuals are living longer, retaining their teeth, this is going to come into our general day-to-day practice with looking after these patients with bleeding disorders. We talk about polypharmacies. When you have more and more drugs, you have dry mouths. When you have dry mouths, you get more decay, and then you have risk of even more disease later on in life that they didn't have before. They weren't a risk of having caries when they were younger, but they are as they get older. Smoking, again, 2 million articles written about that. Okay, obviously the biggest association with it is oral cancer, but poorer healing, progression of periodontal disease, implant failure. And these individuals need our help to make the connection, because that is really important. But if we go back to the real day-to-day dilemma, gum disease in individuals with bleeding disorders, okay, we know that there's a high proportion, and this is an old study by Fisk, but then there was a contradictory study saying, well, actually, there's no evidence that it's any worse than any other normal individual, healthy individual. And that's because it's such a common and prevalent disease. There's a pilot study talking about women. Women and von Willebrand's disease is very, as we said, the Cinderella. Now we're talking about this very much more. But again, they're saying that if of the patients that they looked at, the women that they interviewed in this particular study, there was a direct correlation with access to dental care and their bleeding experience. If they'd been to the dentist in the previous 6 months, they had a statistically significant lower experience of oral bleeding. But this is really important, and this is helpful, albeit not enough evidence, Kate, if you think about what is actually written. But it is really helpful when we know there's a systematic review of everything that's been ever written about, and they can actually say now, it's not about your bleeding disorder. They're not more susceptible to periodontitis. It's mild in these mild patients, which, as you know, is 70% of the population of those who have von Willebrand's disorder. And they don't have a more pronounced inflammatory response to the biofilm. It's just the same. And knowing this helps us, because then we can say, let's just do what we do for everybody else. Let's treat the gingival inflammation. So we'll go back onto that now, which is really what can cause a bit of anxiety amongst patients and dentists. I'm talking to a group of dentists, so this can be like a 30-second slide, well, 3 seconds really, because you know this, I'm preaching to the converted, all right? But I don't know who EHC are going to send this video to. And of course, if we don't treat it, we're going to get more periodontal destruction, eventually spontaneous bleeding and tooth loss. And the good news, it's easy. If you show the patient where the plaque is, and you tell them actually removing the plaque is all you need to do, it is that simple. So I'm so glad we have the hygienists in the audience today, because you guys are key. And I can't do I have a haemophilia clinic twice a week, and I cannot do it unless my hygienist is sitting in the bay next to me, because she does pretty much all the work. And that's great. And especially if dentists are concerned and we see them with a hygienist and we can report that actually the bleeding is fine, then we can write back to the dentist and say, we did it was all fine, crack on. It's really helpful. But it is important to understand that people's bleeding experience is different, their phenotypes are different, and certainly the environmental, social, genetic factors that can impact on their gums are still going to be in play if you have a bleeding disorder. So I think that's what Alison was trying to say. It's so easy to say, just you need to brush your teeth more. Okay, and that's really insensitive for somebody who wakes up with blood in their hair, blood on their face, blood on their pillows. They have to wake up an hour before the rest of their family so they don't frighten their kids, and change their sheets every day. And this is what you hear day in, day out. Okay, it is essential. So try to tailor it to the person as much as you can so that they can feel confident. Okay, I have my students say, oh, their plaque score's still the same, Ms. Nannayakara. I said, what did you do? Did you brush your teeth for them? Did they feel how you were doing it? Did you hold the toothbrush for them so they know what sort of pressure to use? We just have to be really empathetic and tailor our messages for each patient. Okay, we say, oh, pea-sized amount of toothpaste, for example. That's helpful. That's visual. Using these plaque disclosing tablets is also very helpful because they can see. Plaque is really tenacious, okay? It's really sticky. It's hard to remove. If it was that easy, we wouldn't have a global problem of gingivitis and periodontitis, okay? And although we know now that an electric toothbrush is better in terms of efficacy of removing plaque, sometimes it's not the right thing for the patient to start with. But if you highlight the plaque and they just remove it on where the stain is, it's really helpful, okay? And then they can use it. But let's talk about you guys who are going to be helping, and I'm sure you know this. It's because in our attempts to remove these deposits, we can cause bleeding because the tissues are already inflamed, okay? There's no getting around it, okay? But we can do change our protocols in order to be more gentle. So perhaps we wouldn't start with hand instruments that are sharp. We could start with an ultrasonic. We can start with the marginal gingival health, just make sure that that is as good as it can be. And then we can try to manage the bleeding with topical measures. Very, very few of my patients need to have factor support for their periodontal care. Okay, and that's because we get confident at using topical measures, and they are really good, and they have a strong evidence base going back to Professor Sindut Pedersen's work, which I can't quote because it's so old. People don't like it when you have old references, but it's been, proven to be extremely effective, particularly topically. This is tranexamic acid, which is the cytocapron that Alison mentioned. I know it's not available all around the world, but we are trying to lobby various countries for that because it's really cheap and everyone can have access to it, and it's very effective. It stops the clot from breaking down, and it has as good more effective use topically as if you ingest it or if you have it intravenously. So although our patients will come with tranexamic acid on board, either intravenously or orally, we can use it in a very, very effectively chairside. Some hospitals are very lucky. I think the Eastman's luckier than we are. They might have a pharmacist who can make up the tranexamic acid as a mouthwash, but it tastes bitter and it has a very short shelf life, and so you don't always have access to it. But if you break it up and you dissolve it in water, it's just as good. I've heard some haematologists tell patients, just use it as a mouthwash and then swallow it for the systemic effect. I would challenge them to do that. Would you imagine washing your mouth out, rinsing that's bleeding and then swallowing it? It works fine topically, and then you can take the oral tablets. The half-life of tranexamic acid is quite short, so really you want your patients to have had that the night before, and then, most ideally 2 hours before your procedure, if you're having it orally systemically. But you can use it topically in the chairside very easily. As I said, not every country has access to tranexamic acid, so aminocaproic acid is also a reasonable alternative. How I like to use it topically is actually to crush it, because actually it goes into a really, really fine powder, and all individuals will have, if you have access to it, they will have it at home. So they can take it to their dentist. And if you crush it up and put a tiny drop of water to make it like a paste, and you can put it on the gum, it works really effectively because it's in a high concentration and it will stay there, and it will help stabilize the clot. This is a Glanzmann's patient, by the way. That's why it's a lot of bleeding. Not patients don't do that. In countries where South America, this is very popular, bismuth subgallate, and it's sort of an alginate type of material, which again they make into a slurry and they slather it on. We're lucky to have access to other things like fibrin glue, ferric sulfate. Expasil is particularly good for restorative procedures, which is an aluminium chloride. And then we have oxidized cellulose, and this works quite well because again, it's like a scaffolding. It helps to keep the blood products there because the bleeding is going to be, the primary hemostasis is going to be delayed. So these individuals will, particularly if you have, with the exception of type 3, which you've heard now, there's almost the virtual absence of von Willebrand factor. If you have a type 1 or a type 2 with a reasonably manageable bleeding phenotype, it's the primary hemostasis that is going to challenge. So they will stop bleeding, but they will just take a bit longer. Okay, it's just prolonged. So top tips, I would say, from having done this for 20 odd years, it is really helpful to invest time in improving home care. Just because when the marginal gingival inflammation is better, then you're going to have less intraoperative bleeding chairside when you're treating the individuals. And then surface area. Actually, and that goes with good isolation as well. Saliva is the enemy. it breaks down clots. It has fibrinolytic activity. So using your nurse, making sure that they're keeping the field dry, and you do a little bit at a time. Ironically, managing postoperative bleeding from an extraction site, which I'll go into later, is actually easy because it's a very localized spot, albeit a lot, but it's localized. Whereas if you have your whole mouth bleeding from a scale and polish, and there's saliva everywhere, and the patient is trying to rinse and spit at the same time, it just promotes and potentiates the bleeding. All right, so do a little bit at a time, get it to stop bleeding, okay, and then move on. Maximize, you can't overdose on tranexamic acid, particularly because you're using it topically, but pressure, I'll go into it in a little bit more detail, but it is firm digital pressure. Don't dab it, okay, because that clot is taking a long time. That's what von Willebrands is. So just be really patient, put your fingers on it, a lot of pressure, damp gauze helps, but a lot of pressure, and then wait for that hemostasis and then move on. And then the whole experience of the patient and the dentist, hygienist is just much easier to manage. And again, don't dab it with the high volume aspiration, okay? You just need to leave it there. When you think it stopped bleeding, stop, watch, count to 10. You'll see it just where it's oozing, okay? Because you've got a nice clean field to work with, and that's where you're going to go back to with your finger. All right. Vasoconstriction, Alison talked about that already. It does have good vasoconstriction, and some people, I don't know where that happened. And you'll see on the pictures here, I don't know if you see my thing, you'll see the vasoconstriction as you administer it. You'll see the tissues blanching. Okay, people sometimes say, oh, but it causes a bleed wherever I inject, okay? But I think the benefits outweigh the risk of that small spot, particularly with the fine gauge needles that we use. And then there's the risk assessment, okay? Not all tissues are going to bleed just because you're doing a scale, all right? Some people do have, we call them they're not susceptible. They're periodontally not susceptible. You can have a lot of plant and calculus, but their tissues aren't bleeding. Remember, they're not going to bleed more and have more inflammation just because they have a bleeding disorder. So you can assess the marginal gingival tissues. And I think, well, actually, if that individual didn't have a bleeding disorder, those gums look all right, okay? So even though the hematologist might have a sharp intake of breath, when I phone them up and say, I'm just going to carry on, you're all right, stand down, it's not that bad, you'll see that actually it was minimal, all right? So you'll see on the right how the individual looked just after this, sorry, this is before, I beg your pardon, and this is afterwards, all right? So yes, there's some inflammation. I was able to manage it with topical measures, and then we don't need to make this a more drawn-out procedure. And desmopressin is great, but it is boosting and causing the release of your stored von Willebrand factor. So you don't want to overdo it, because then the patient will run out and they'll be depleted of their stores. Okay, so you just really want to be mindful of things like that. Just because you have access to the hematologist, hopefully you won't need to call them every time now. And this is another risk assessment tool that Alison published some time ago. And it's just to think about go ahead with certain things like an examination, impression making, probing. If the tissues aren't completely inflamed, they're not going to cause any bleeding. And then just think, do you know what, even with an individual with a serious and severe bleeding disorder, there are things that I know I can do without causing bleeding. So I'm not going to cause any problems. Then there's the ask and think section, okay? So a stainless steel crown, a rubber dam clamp, pulp treatment, none of those are going to cause gingival bleeding unless that individual has very inflamed, swollen gums, and you're doing something as an emergency and it's not reasonable to spend time to delay it and get that marginal gingival health up. Okay, so you might need to have a conversation with there. The subgingival scaling is exactly the same. How much is it going to bleed? And then there is obviously the ones that you definitely do need to start, all the invasive stuff. So the inferior dental block and the lingual anaesthesia, probably mostly historic now because we use buccal articaine 4% as an infiltration, but certainly all of those surgical procedures you would need. I guess this is a bit of repetition, but it's really important. Even if it is the amber category, ask, think, I know that I've got topical measures. I know I can manage that without any preoperative haemostatic support, so we can crack on. And again, don't be frightened by the bleeding. Just take time, clean everything up, look to find where that bleeding spot is, and then work with very specific, firm, prolonged digital pressure. If you want to use a gauze, you can do. If you want to use cotton wool rolls dipped with the tranexamic acid, that's all fine. And then you've got things to say, well, actually, those tissues are really inflamed. What am I going to do? I need to stop and think about it. Actually, probably a lot of that's going to come off with an ultrasonic, and then perhaps the tissues underneath will be de-epithelialized because of the inflammation. So I might have a conversation with the hematologist and think about whether we do or don't need cover in this case, and we will have that conversation. Good news, the majority of inflammation is gingivitis, okay? Actually, it's very mild. We know that good oral hygiene measures, like the case that Alison talked about, you know, her patient just responded, had bleeding constantly for years and just responded to oral hygiene measures. Use the disclosing agents, show the patient, brush their teeth for them if they're needed so they know how it feels, and then let them do it. They can video it on their phones so that they have that as a resource for when they go home. Right? Don't underestimate how hard it is to make lifestyle changes, and that's what we're really needing to do. And whatever we can say or do to make that person stop and think when they're in their bathrooms the next day to do things slightly differently is really, really important. But then there's the periodontitis. There is lots of inflammation. There might be some bone loss, pocketing, much harder to access. Okay, and then that's the time when I would be thinking about tranexamic acid as my go-to, and maybe prolonged mouthwash for 2 or 3 days afterwards. That's helpful. We would ring the patient as routine the next day. I say we, the team, which would be the haemophilia nurses, just to ask them, are they okay? Because don't forget, as already been talked about, bleeding is very variable for individuals. Okay, what some person might think is bleeding, somebody will say, it's fine. You know, so we just phone them up, check. Do they have the taste of blood in their mouth? Did they wake up with blood on their pillow? Sort of specific things that might, give you an idea that they're bleeding. But very rarely have we ever needed to get somebody back in after an intervention. But this is the same individual. This is the picture I took just at the end of their treatment. Okay, obviously I'm not going to do the whole mouth in a case like that. There's just too much surface area. I'm not going to get control. I'm not going to get the saliva to, you know, off the dentition for that whole time. But look, when they came back the second week, that's just a week later. All right, so this individual, I'm going to do the second half side. You'll see what the side that I haven't done. And this is all healing beautifully. So that means that the patient is confident that they can floss, use interdental brushes in a way that they wouldn't dream of doing that before. Okay, and so big hashtag slogan, healthy gums don't bleed. And it's easy to be put off by the prospect of post-operative and managing the intraoperative bleeding. But actually, when the treatment has been done, the patient can feel the benefit, see the benefit, taste the benefit, and then they will just feel better about managing their own home care, which we all know is the single most important predictive factor in terms of long-term outcomes of this treatment. Dental extractions, we know that we have to liaise with the haemophilia centre. They would almost inevitably give some sort of replacement therapy. We would ask our patients to use tranexamic acid as a mouthwash, and of course we will use our full armamentarium of topical measures to get bleeding to stop at the chair side, so that we know that there's hemostasis when the patient leaves our chair. And why I said dental extractions are a little bit easier to manage is because you can see that the bleeding is very confined. It's not affecting a big surface area. So we can plug it, we can pack it, we can put fibrin glue in it, we can put Surgicel in it, we can put a horizontal mattress suture in it. We can really, really firm up and support that initial fragile clot. I put this in because, beg your pardon. The picture on the right is actually a thing of what not to do, okay? Because I've already talked about the actual fibrinolytic impact of saliva. So if you just leave the patient with a massive gauze pack in the mouth and then you wander off to see your next patient, that is just going to pool up with blood. Okay, there's really no firm pressure there at all. So you really want to roll it up really small, and I find it helpful to use cotton wool rolls, okay, because that will get into the spot. Because when patients bite, the rest of their teeth are going to come together. It's very difficult to be confident that you're going to put pressure on the bleeding area, on the socket. So actually, if your pack is the size of the hole that you're going to put it in, when the patient bites together, there will be some pressure. Okay, I know it sounds simple, but you'll be surprised how often I get called to the surgery department to manage somebody who's bleeding for a long time, and they're sitting there drooling blood and pack everywhere. You know, it's not doing anything. Right, so you want to be very, very specific, right on point. As I said, we use Surgicel and we suture it. It's got a word of its own. Oh, why is that going on its own? I don't know. Sorry. Better keep my finger on the pulse. We use immediate dentures as well. That has an impact, obviously aesthetic for your front teeth, but also it will keep some pressure on, tell the individual not to take it out till the next morning, and that will have given you time. Right, so the haemophilia comprehensive care team. All right, we're all lucky now, having known the audience as I do now. You're all working in hospital, so you do have this privilege, great word, to be able to care. But it is a shared care approach, and there's two very important individuals in this, and that's the patient as well as the general dentist outside in the community that need to be involved if we're really going to do this properly. But let's try to understand why patients don't access regular dental care. It is multifactorial. It isn't just their bleeding disorder. Sometimes it's the cost. It's often the fear, their past experiences. You know, sometimes it's because the patients don't have any pain, so they think, I can't face it right now, so they don't go. And sometimes it's the skill set. They're concerned about the dentist being able to look after them. This is a study we did some years ago now, but we did survey 105 patients, and 20% of them had unfortunately had disease-specific barriers for them accessing local care. And 17% of them were actually apprehensive. All right, so it wasn't their disease at all, they just were scared. All right, they lacked confidence in their dentist. They felt the dentist didn't have enough knowledge, and that obviously they had past experiences. And then, of course, they felt the dentist didn't have the ability to look after them. And a follow-on study for this is we surveyed 50 dentists and found that they actually had had a past bad experience, or they felt uninformed and unable to. So communication is key, all right? It's really, really important with all of the individuals who form this shared care arrangement for each individual. All right, we need to empower people with bleeding disorders to seek primary care in the first place regularly, and we can do that easily with a patient information leaflet. And that helps because it tells them that actually all these things that they can have done without needing to have factor replacement therapy. They don't need to come into the hospital. And then there's the dentists. Okay, we need to demystify them. Having the undergraduates there is really helpful. Having the hygienists on your clinic is really helpful, because then hopefully they will realise that these individuals aren't difficult to manage. And actually, when they've had cover, they're hemostatically mostly normal, or over beyond if we haven't communicated well and they've been boosted too much. That sometimes can happen. But what we have at the London is a letter that goes to the dentist to say, this is the bleeding disorder, it's perfectly fine and safe for you to look after this individual. And then, like we heard before, there's my name, contact number, we're here for support. That's what Alison said. All right, so, and it's signed by the consultant haematologist and myself. So both the patient and the dentist realise, okay, safe to go ahead. There's nothing to worry about, but I have a backup plan if something goes wrong. And then there's the haemophilia team. Make no mistake, even if patients don't go to the dentist, they will not fail to go to the haemophilia appointments or their haematology appointments with Willebrands. And sometimes they just telephone follow-up appointments. So actually educating, we've got a fantastic nurse team, and they're great with the dental messages because they are so simple, okay? Frequency of sugar causes decay, decreasing frequency of sugar reduces your risk of decay. Gingival inflammation causes gingival, the plaque forms the biofilm that causes bleeding, and effective plaque control will remove that. And they boost these informations. If at very least questions that they ask of their follow-up appointments is, do you have a dentist? Are you going regularly? That's huge. Is to have that conversation. And they are very well placed to do that because they do have interaction regularly with the individuals. Some extra ones for the postgraduate level of information for this is the haemophilia nurses. They can talk about fluoride and chlorhexidine, which we as dentists know a lot about, but actually haemophilia nurses telling patients that is quite helpful. And this is the shared care approach that we have. And it's very simple, although it looks like a complex flow diagram. We have the comprehensive haemophilia care centre. And of course, we interact with lots of hospitals around our area. So they still nominally have control over the hemostasis plan for their patients, which they will tell us. But this is the dental liaison letter that I showed you. It's basically to the dentist to say, it's safe to look after this patient, but please do the routine care and maintenance. But if you need us, if it needs treatment, we're here for you. And we can fast track them to come to the London for that treatment. Thank you. And they can go back to the dentist afterwards. Of course, there are some urgent cases or people who live in communities where there's still a stigma about bleeding disorders or the dentist really is refusing to help, and they can come directly to us. But that's relatively few. I have over 1,200 registered patients at just my hospital. So I can't see everybody. But actually, if we can make it an efficient service so they can access when they need it, it's much better. Okie dokie, how are we doing for time? Oh, are you okay so far? I just wanted to tell you a little bit of, Alison asked me to touch on some laser therapy that we've been using on individuals with rare inherited bleeding disorders, more rare than the rare bleeding disorders, which is Willebrands is not rare, but in the bleeding community. And of course, in this scenario, type 3 von Willebrands disease are the patients that I've been treating. And we had a lovely story, and you had stories from it. And this is a story of my patient that made me change how I did things. She's a lovely young girl, and she had Glanzmann's disease, and she had just the worst quality of life you could imagine. Her parents didn't want to deal with it. They shut her off in the back of the room. They didn't even bring her to her hospital appointment. She was a minor, that means under the age of 16 in the UK, and she would come to her hospital appointments on her own. That was her when she sat in the chair with me. That's her day-to-day bleeding. I haven't touched her, I've just said, good morning, can I have a look? And that's her. She drinks milk to mask the taste of the blood in her mouth. She has to wake up before her family to wash her hair, clean her sheets every single day. And she was so anemic that she was transfusion dependent, so she would need to have a blood transfusion every month and have iron transfusion because her parents wouldn't allow her to have any contraceptives to moderate her periods. So when she bled, she bled. And I just would see her so regularly, and I was making not a jot of difference for her because she would not brush her teeth, and she had a plaque score of 100. And when I treated her, the bleeding was so intense that she would need to be admitted to hospital for 3 or 4 days to manage the post-operative bleeding from my basic scale and polish, and she didn't have advanced disease. So one day I was thinking, oh, I need a magic wand. If I could just manage that inflammation, I know I could clean her up with. Because when I would book her an appointment, the haematology team would say, oh, Lochana, can we just do it in the next financial year? Because it costs so much to manage her. It isn't just the platelet infusions. It isn't just the hospital stays. It was all the products she needed afterwards for the post-operative bleeding. And I had many patients at that time, some years ago now, who all had to be admitted to hospital for post-operative bleeding after my basic hygiene intervention. And I was thinking, I just need a magic wand. And one of my colleagues said, well, we could think about a laser. A laser does have a reasonably robust evidence base for managing not bleeding, but just inflammation, reducing inflammation. And so this is a case series of 12 patients now. And I said to you before, lots of disease, lots of bleeding, socially embarrassing, couldn't eat out in public. As I said, their hemoglobin levels were between 4 and 6. One patient had had 13 hospital admissions for supraventricular tachycardia because she just literally didn't have enough blood in her mouth, in her system for her heart to work. And that's because they would just have all of this blood transfusions, but they were just bleeding it out. They had no other, they didn't have gut bleeding or genitourinary tract bleeding at all. It was just oral bleeding. We don't need to go into this, but that's her plaque score. And we've used the low-level laser on them, okay? And it has got a good evidence base for a biomodulation, biostimulation effect, okay? It acts in the infrared spectrum, so it's actually very safe, and it is absorbed by colour, which is really helpful because these individuals have got very inflamed, colourful tissue. And of course, it is non-invasive. Okay, so I've been able to use it with a protocol that I developed at the London, which is just 2 or 3 times a week to help build up the effect of the laser on the tissues, and that basically reduces the inflammation. You do need to wear eye protection for it because it will travel for 11 meters if it's not absorbed. But when it's absorbed in the tissues, it's perfectly safe. And you can use it in a non-contact way so that it doesn't cause bleeding, okay? And you just have to move it very, very gently just because it does develop a bit of heat, so you don't want that to cause any harm to the pulpal tissues. But it's 30 seconds in each sextant, so the patient's in and out in 10 minutes because you do need to see them a few times before the intervention. And what did I find? Not that, oh, I could manage it with less bleeding. I had the patients, booked in to be admitted, platelets on standby, but they actually stopped bleeding in the chair. The patient on the left at the top is the Glanzmann's lady, and the patient on the bottom is actually a von Willebrand's type 3 patient who had had all of those hospital admissions for supraventricular tachycardia. And she messaged me the day after I did this treatment. She said, oh my God, my hands, the palms of my hands have turned pink. I can pick up my daughter again. I've got some energy. And the haemophilia team ringing me up saying, oh my God, her hemoglobin's 9. It hasn't been 9 for years, just to stop the bleeding. And when you stop the bleeding, you can empower these individuals to brush their teeth, okay? You can give them access to primary care without having to have long stays in hospital. None of them need transfusions anymore because they're not having chronic blood loss. And of course, cost savings to the NHS. If you look at what actually one patient costs to do, and this is through audit, we looked at my patients and how much factor cover they'd needed. And the von Willebrands type 3 lady, she was giving herself hemate P every 3 hours for that level of bleeding that she had. I mean, that's £2,000 a day plus for months. And then there was a patient with severe haemophilia with inhibitor who was on fever three times a day. And so he'd actually consumed £1 million worth of fever before he was referred to me. And he'd had a Hickman line put in because he had a shunt put in because his veins were cutting out, and all he needed was an extraction and some treatment. So we can, save some money, but more importantly, we can help these patients. 3 minutes. I probably won't play this now, but it's a patient video talking about how this impacted and his quality of life. And I'll just finish there to say, actually, I hope you feel, actually, Alison was right. The dentistry bit is actually simple. It's just helping the patients to understand that and making sure that you have some support with the haematology teams should you need it. Thank you. I have finished. I wanted to have time for questions, but we've run in. But thank you. Oh, questions. Hi.
You advise the diode laser application to every patient that have von Willebrand?
No, I wouldn't, to be fair. And it's really important. Thank you for the question. I'm sorry I didn't make it clear enough. Those were the very rare Bernard-Soulier Glanzmann's type 3 von Willebrands, and that's in individuals who'd previously, their phenotype is so aggressive that they bled enough to need a hospital appointment to be a hospital admission for the hemostasis, okay? And the reason for that is because I don't want to make it less accessible. If you go home with the impression that that's going to make everything better, we are getting some funding now to look at some research to work out why. I mean, the acts of that patient, she would bleed so much that the hematologist would have to come and hang up a bag of platelets to the dental light just to get her to stop bleeding sufficiently to get her back into the hospital bed. I mean, so it was quite severe. So for her to stop and to clot in the chair, something's going on, but we don't know why. There's one haemophilia mouse model, so not even von Willebrands, or Glanzmann's obviously is a platelet disorder, so it's primary hemostasis. And it did show that the platelets got more sticky and aggregated better after exposure to the laser diode. But it is a really helpful adjunct, and it has unusually and not planned made a positive impact on hemostasis. Why, I don't know. So it's difficult for me to say you need to have that for all of your patients. But it helps if they've got very severe engorged, inflamed tissues and you can't just touch them because they're bleeding, and that inflammation, having that reduced inflammation at the beginning is helpful because you get less intraoperative bleeding, you would imagine, and therefore the post-operative bleeding challenge is less. One of my patients who was von Willebrand's type 3, she was so scared of the treatment because of all her past bad experience, because the laser stopped her bleeding, she didn't come back for the treatment. I was so cross. I thought I'd won her over, but she didn't. And so I know that it works in terms of reducing the bleeding, but 8 months later, she was back. You have to remove the biofilm. It's not a magic wand that I thought that I was just thinking. I just wanted to be able to access the tissues, clean them up, to get the bleeding to stop, the gingival inflammation to resolve. Okay, but standalone, I don't think it's going to work.
About the pulp extraction, extirpation.
Yes.
Is there any sign to anticipate if there will be blood or
No,
not?
if you think back to the anatomy of it, it's not. The inflammation and the profuse bleeding you get in a hyperemic pulp is because of the inflammation in the pulp chamber and the root canal system. And when you remove that, the bleeding will stop. Okay, yeah. Sometimes you can inject local anaesthetic with vasoconstriction, but yeah, you definitely don't need cover or replacement therapy for root canals. I was saying to Kate, I had a whole list of all the things that you could do and could not do, but I didn't have time. But everything can be done without factor replacement therapy, except when the tissues are inflamed and your rubber dam clamp might cause pain, bleeding, or obviously surgical interventions. And that includes hi.
Is it wise to treat a patient, a child, a pediatric patient, with a bleeding disorder, like if you schedule a cleaning, scaling, to do it by quadrants.
Sorry,
Just
to do it?
by quadrants,
Yes.
just to test the water.
Yes, definitely, definitely. 100%. That is a good idea. If you have an individual who needs factor replacement therapy or platelets beforehand, then possibly you would just get on with it. But for at least 70% of the individuals, more 90%, and in my case, all of them except type 3 from Willebrands, I don't use factor. So if I had an individual who'd been referred in because they'd had profuse bleeding and the dentist was concerned, I would just test their phenotype out. Yeah. And it's a great idea. For the dentist as well as the patient. Yeah.
I didn't understand how you can currently manage the bleeding for a general scaling.
Because I don't do a general scaling.
Yeah, so
I do just a few teeth at a time.
And then, how do you manage the bleeding?
So pressure with the gauze pack, yeah, or cotton wool roll, and the isolation, the saliva. Get that out of the field. And you can even, you know, sometimes you don't always have an assistant, so you can just use a gauze pack to, you know, just wipe the tissues, okay, and a low volume saliva ejector.
And would you use local anesthesia for scaling to stop the bleeding? No.
Because as you saw in my pictures, it's very specific, the point of action of that vasoconstriction, and that's helpful in an extraction when the point of bleeding is localized, but not a whole quadrant.
Which patient groups would you say should be treated in secondary care only? I work only in community, we don't have a dental hospital nearby. And sometimes I find that quite difficult, whether to refer them to oral surgery and I have to wait,
Yes.
or just treat them in clinic.
So if you have the telephone number of the haemophilia unit where, or the haematology unit where the individual is, you can just tell them you're doing it. Okay, as Kate said, a lot of them will be able to self-administer their product, and so long as they know it's happening, they're usually very happy that you're there to look after them. And with your topical measures, then the chance of you having a bad experience or a prolonged bleed is very low, because the extraction needs the product. If some of our patients are just anxious and they don't want to self-inject, even though they are taught from a very young age, they just can't get fit, and then they need to come in. So yeah, well done. And how nice for your patients to have you to look after them. They don't have to go to the hospital and wait for months and months. Great. Thank you. Any other questions?
I think we're done.
Good. It's lunchtime. Thank you. Please do email me if you have any queries or catch Alison. Thank you.